Okay. All right. Well, good evening, everybody. Welcome to the Smith-Kingsmore Syndrome Foundation's talk on pediatric epilepsy. Tonight, we are honored and thrilled to have Lyndsey Prange with us tonight. She is a pediatric nurse practitioner specializing in epilepsy, practicing out of Duke Children's Health Center. Welcome, Lyndsey. Thanks for joining us.
Thank you so much. Thanks for having me.
Yeah, I think it's really cool, and our viewers don't know this, but you're already kind of connected to us and to our foundation because you see some of our families already, or at least I know one of them for sure. So
Yes, they're wonderful. They're wonderful. So I'm honored to help take care of them.
big thank you for supporting us and our children and what we do.
Yeah.
All right, so let's get into the important stuff. Let's start off with a question that seems to come up often in the SKS community. It's about looking for signs that your child is having a seizure and what to do. I call it the how do you know, right? The how do you know question. Since we do have quite a few families that are not seeing seizures yet, fingers crossed, that what should they look for? How should they respond? How should they be prepared as parents?
Yeah. Seizures, everybody thinks of the convulsive seizures, which are often quite obvious, right? But seizures can look lots of different ways. And so I think the more subtle seizures are what parents tend to be more concerned about. Could I possibly miss something when my kid's having a seizure and I don't know it? So seizures can, like I said, have lots of different appearances. Some of the more subtle ones are kind of staring, abrupt behavioral arrest with staring, kind of non-responsive. Sometimes there can be breathing changes. Sometimes there can be, subtle facial twitching or eye deviation to one side. But I think the thing to keep in mind about seizures is that they tend to be stereotyped. So kids can have lots of different funny movements, even babies, right? But the thing with seizures is that they tend to be stereotyped, so repetitive over time and look the same. Sorry, hold on. Okay, well, I'll see you guys in a minute. Sorry about that. It's bedtime, so it's hard to keep them away. But yeah, so I think that's the main thing. And certainly if there's any, behavior that they're having that's concerning, often if you're able to video any part of it on your phone, it can be quite helpful for us to see, providers, pediatricians, if you don't have a neurologist, and they can kind of help sort things out with that.
Great. Yeah, that makes a lot of sense. A lot of good things to look out for. Adding on to that question, though, are there particular situations or activities that can cause seizures or put our children at a greater risk to have a seizure? Specifically, some of our families are interested to know about if hot tubs or pools cause issues or increase the risk of seizures for our children. Either if it's a first-time risk or is it a risk if you've already been having seizures. And are there other common seizure triggers? Like I think we all hear that flashing lights and video games can send you into a seizure. There's even warnings on some of those things.
Yeah.
What can you provide? What can you tell us a little bit about, where we might be more at risk or children might be more at risk and what's fact and what's fiction?
Yeah, so there are, reflex epilepsies or hot water epilepsy, cold water. There's lots of different things that can trigger them, but reflex epilepsy is a very rare type of epilepsy. And so often, it's something that happens every time. So if it's hot water epilepsy, it's repetitive. It's not usually something that they haven't had an issue with it and all of a sudden it develops. But I think the thing to keep in rare is that's a rare type of epilepsy, but it certainly can be. And yes, as you mentioned, the flashing lights, everybody worries about that. But often, there's certain types of epilepsy. And so if that's not a trigger for somebody that has epilepsy, it doesn't become a trigger for them.
Okay, sounds like we should know our case for our children. If there's something that you already know is a trigger, that's likely going to become a trigger, but not necessarily some of these other things would become a trigger if you've already been exposed to those things and it's not causing seizures. Probably.
Yeah, like you mentioned with the hot tubs, if the patient's been in a hot tub and done fine, I wouldn't expect that later they would develop seizures because of that.
Okay. And then we started talking a little bit about water. And what about safety around water and pools, right? What are some of the steps we can take to keep our children safe, around pools or just in seizures in general? What are some good steps to keep the children safe?
Yeah, so obviously there needs to be a lifeguard on duty or a parent in the pool or some caregiver in the pool with them if at all possible. We like pools better than open bodies of water because you can see the bottom. And really just, making sure that someone's watching and can intervene if needed. But in general, patients that have epilepsy, if it's well controlled, swimming isn't a contraindication. It's just that people need to be aware and ready to intervene if there were to be a seizure.
Okay. And I think that one of the things that Sarah and I might talk about a bit is like nighttime seizures. Now, we're not having seizures yet. Charlie isn't having seizures. But there was a time where, we were like, how do we know, right? Maybe he's having a seizure at night or in his sleep. So that's kind of scary. I would worry about knowing whether my child was having a seizure at night. What are some good ways to monitor for nighttime seizures or things that we can be aware of? And are things that we can do to protect our children, if they have a seizure at night or from SUDEP or something like that? What are ways that we can protect our kids at night and be aware of what's going on?
Yeah, so I think that's the main fear of most, parents of children that have epilepsy is, like you mentioned, SUDEP, the sudden unexpected death of epilepsy, which is extremely rare, but can happen. It's about 0.4 per 1,000 children with epilepsy. But yeah, that's the fear. And often if that happens, it's when the child is not supervised. And so it tends to happen more when the epilepsy is not well controlled. And so, as you mentioned, nighttime, there are different seizure detection monitors that can be helpful for nighttime. The DannyDid.org website does a really good job listing, and that's DANNY, DID.org, listing the different seizure detection monitors with links to all the different ones. Often those monitors require some type of kind of rhythmic movement to detect the seizures. Some are just video cameras where it connects to the parent's phone and sends an alert that way. Some are pads that go on the bed that detect the movement and alert a family member. Some are watches. And again, this varies on the size of the child. Some of the watches, some are apps connected to Apple Watches. The Embrace is a watch that has its own band, but those often don't work well in younger kids because of the size of the wrist. And often in kids, depending on their mobility and movement, if there's a lot of movement, it can have false alarms. But those are some options for kids, with epilepsy to help detect seizures, maybe when they would be unwitnessed. But you also mentioned, parents worry about my kids not having seizures, but, how would I know if they have one during sleep? And I think that's the hard thing, is that I wouldn't recommend everybody just run out and buy one of these monitors for their kid just so that, they're expensive. And so sometimes just a baby monitor that you can adjust the sensitivity. And so, if there is any sort of noise or cry out, it'll pick that up and perhaps wake you up. And sometimes the baby monitors that have a video, if you do hear some noise, you can kind of see on the monitor if anything suspicious is going on.
Okay. Yeah, definitely a scary topic. Nice to know though that SUDEP is rather on the rare side. So that's definitely a little bit mind relieving, at least for us, for sure.
Yeah.
And I imagine that changes as the children age, right? And you get a little bit more stable when they're sleeping. Maybe some of those monitors are maybe a little bit more helpful, or maybe when they're a little bit more mature. I guess that would just.
Yeah. Yeah, and I think, one of the main things is just if they do have epilepsy, taking the medications as prescribed is key in helping to kind of control the seizures. But, often there aren't, like we said before, triggers to a lot of the seizures. So.
Right. Great. So, that kind of brings up another question for me too. This is really about age. And how does age play into the likelihood of having a seizure? And we're thinking about, children with SKS and, children in general. Is there an age or a time when the children might be a little bit more at risk or less at risk? Are there, the times when, maybe we're going through a growth spurt or something like that, that would be more of a risk time? And is there a time when you kind of age out? So if you're hitting that 12, 13, 14, or you're beyond that, you're like 17, 18, you're past, for the most part, your puberty, and are you less likely at that point to see a seizure if you haven't had one so far? Or what do you think?
Yeah, so I think the brain is always changing in everyone throughout childhood and adulthood. And so whenever there's a genetic mutation that affects the brain or a structural brain abnormality, as the brain is changing, those mutations can have effects at certain times that they didn't have an effect earlier. And so that's why it's sometimes, parents want to know, well, this has been present for their whole life, so why did seizures start at 5, 10, but they weren't present when they were younger? And I think that's kind of the reason, is that we don't always know with these mutations when they have their effect and how. So I think it's hard to say that there's, an age where, they're safe from not developing them when there is a genetic mutation or structural brain abnormality. You had other questions in there, and
Yeah, sure. So
please remind me.
Sure. So to be like a little more specific, when some of our children, they start to go through puberty or they're hitting a growth spurt and the body's doing some rapid change, is that a time when we're more at risk?
Yeah. So, in children that have epilepsy, if they're on a medication and go through a big growth spurt, sometimes, they can kind of outgrow their dose and may need a dose adjustment based on weight changes. And then sometimes, as they go through puberty, that can be a time that can either, in general with epilepsy, kind of make seizures better or make seizures worse. So yeah, there are certain times.
And no, is there a rhyme or reason why some of SKS children start seizures earlier than others? Is it just luck of the draw because that is what's happening in the brain for this child versus someone else? Is there any type of understanding of why it's earlier in some and later in others, and not at all?
Yeah, I mean, I think it's just that mutation and how it has an effect and when it exerts that effect. I think, as to maybe why seizures develop at one age and not another. Sometimes in epilepsy, there can be certain types of seizures at certain ages that we don't see at other times. In infants, there can be infantile spasms, which we tend to not see when kids get older. They can kind of change and become a different type of seizure. But yeah, as to specifically for why one SKS patient has seizures in infancy and maybe another doesn't develop them until later, would just have to do with the mutation and when it has its effect on the ever-changing brain.
All right, gotcha. Thanks. So looking ahead here a little bit. So we've covered quite a bit of information. Let's spin over to being able to diagnose seizures and the role that EEGs might play, and what is EEG, and why is it important to us? And in our case, Charlie went and had an EEG because we wanted to know what was going on. He hasn't had a seizure, so the neurologist look at that as having a baseline for him. So as he changes and develops, over time, we'll have sort of a baseline. How important is that? I mean, is that something that parents should go off and do if they have a concern that seizures might be in the future, or is it just just an extra step?
Yeah. So, and I'll start by explaining what EEG is. So EEG stands for electroencephalogram. And so that's, they put all the electrodes they measure and put them in certain areas of the brain, and that records the electrical activity of the brain. And so, that's what a seizure is. It's a misfiring of the electrical activity of the brain. And so the EEG, if anybody's had one or seen one, the brain waves look like squiggly lines on the computer screen. And so what they're looking for, there's different types of EEGs. There's what we call a routine EEG, which is just a short kind of 20-minute EEG snapshot in time, what the brain waves look like while it's connected. There's an ambulatory EEG where they hook them up, they wrap it, and there's a little backpack and a button to push. So if there are any spells of concern, we can do those for, up to 72 hours, and then send the patient home. And it's recording day and night, capturing, hopefully to capture a spell in question. And then there's inpatient monitoring, where we can bring patients into the unit to video record, so we can clinically see with a video camera what the spell looks like and what correlates with it on the EEG and the brain waves. And then, sometimes we can do just like a 6-hour in lab if spells are frequent and we're likely to capture it in that time. So what it's looking for is any sort of discharges or spikes in the brain waves that shouldn't be there, that would indicate risk for seizures. Or if they're having these episodes, if we capture them, if it's associated with seizure activity. So it can be helpful in kind of providing that information. If we capture the spell and rule out a seizure, great. If we capture a spell and it lets us know it is a seizure, then we know we need to treat it. And if we're having spells and we don't capture them, but the EEG looks convincing of seizures along with the spell type, then we know that we need to treat. Now, in general, we don't usually we wait until there's a spell with epilepsy concerning for seizure before we then get an EEG. It's kind of our typical approach. But, as you said, you have a baseline to see what it compares to. But in general, we wait for either 2 kind of unprovoked seizures before we think about starting a medication for seizures, or 1 spell concerning for seizure with an EEG highly suggestive of epilepsy. And then we would consider, because the likelihood is high that they're likely to have another seizure. So we would maybe go ahead and start a daily medication to help prevent those. I think you had some more questions in there, and I don't want to skip over any. So
I think you got quite all of them, actually. I think one follow-up question would be, when you talk about medication, are there medications that are common that that would be, if you're talking with your neurologist, you're talking with your nurse practitioner about it, the common ones that we should be aware of, or you might hear about, or some names of medications that we could expect to hear from our doctors?
Yeah, I mean, I think that there's lots of different seizure medications, and some are better for certain types of seizures. So some medications are, good for focal seizures, so seizures that are starting in one area of the brain. Some are good for generalized seizures, so generalized discharges. And then, like I said before, with infantile spasms, we treat those a different way. So it depends on the type of epilepsy and type of seizure for what kind of medication. But I think a lot of people have heard of, Keppra is a pretty common one that people are prescribed. There's many, Topamax, Trileptal, Depakote, the list goes on and on. But really, it's just picking a medication that would be good for the seizure type and the EEG pattern.
Great, thanks. Lyndsey, you've given us a ton of information tonight, and really appreciate it. Ranging from what to look out for to how this is, why this is affecting our children, and how SKS plays into that. If we walk away from this conversation and our families took away 3 things, what would you want those 3 things to be?
Yeah, so I think seizures are scary, and so parents are often terrified of that. So I think if there's any spell that is concerning for seizures in a child with SKS, I would have a low threshold for getting an EEG to see what's going on. I think if the child has seizures, seizure first aid, and trying to stay calm with the seizure. It's important to monitor the time, so because 10 seconds can feel like 10 minutes if your child's having a seizure. So it's important to look at a clock, look at the time, lower them to the ground, turn them on their side, keep the area around them safe, so that they can't potentially knock into something so that something doesn't fall on them, injure them during it. Don't put anything in the child's mouth. They aren't going to swallow their tongue. Try to just keep them on the side. If it's their first seizure, certainly call 911. But if they're known to have epilepsy and this is a seizure, then usually the 5-minute mark from when the seizure starts is the time frame we use before a rescue medication needs to be given to help stop the seizure. So I think seizure first aid is important. And then parents worry about is there something that I'm going to do that's going to trigger the seizures, and often seizures are unprovoked, and so that there's not a lot that you can do to help prevent them. There are certain medications, so if your kid has epilepsy, like Benadryl can lower the seizure threshold. So if they get stung by a bee and they need Benadryl because they have allergic reaction, go ahead and give it. It's just not something that we want them taking daily as like a allergy medication. We know that sleep deprivation can lower the seizure threshold. And so, as I said, there's not a lot to do to prevent them. But if they are diagnosed with epilepsy and are on a medication, taking the medication as prescribed is one of the best things you can do to try to help prevent seizures.
Thank you so much. So I'm just going to pause here for just a minute to see if we have questions from our viewers. And yeah. we do have one that came in, and the question is, do you typically desaturate during a seizure? And if yes, would a device like Owler be possible for night seizure detection?
Yeah. So not everybody desats with seizures. I'm not super familiar with the Owlet, but I think that's the infant monitor that monitors maybe heart rate and O2 sats in infants. And potentially, it's obviously not marketed for epilepsy, but perhaps, again, I think that the key is that if your child has epilepsy and desats with their seizures, then it may be worthwhile to have an O2 sat monitor to put on them during a seizure. And then again, just depending on how well controlled or poorly controlled the epilepsy is, kind of changes management in those situations. But not every child desats with seizures.
And just for the layman guys, desat means
dropping their O2 sat. Sorry. Yep.
They're not oxygenating as well as they normally would.
Correct.
Okay. Thanks. All right. Well, I think I see no other questions in there. Lyndsey, thank you so much, not only for taking the time to talk with us today, but also supporting our families. That's the most important part. So thank you for supporting our
Of
families.
course.
Thank you for the work that you do. We really appreciate it.
Thanks for having me. It was a pleasure.
All right. Thank you. Good night, everyone.
Bye-bye. Have a good night.